Hello, everyone. My name is Zorica Buser. I'm a director of research and regenerative medicine at Gerling Institute and research assistant professor at the Department of Orthopedic Surgery at NYU. I'm joined today with my colleagues.
I'm Charlie Reitman. I'm an orthopedic surgeon in Charleston, South Carolina at MUSC.
And I'm John Hipp. I'm chief scientist at Medical Metrics, which is an imaging core lab.
Thank you. So today's topic is spine instability or spine stability. So the topic has been discussed. A lot of research has been published in the last decade, but yet the evidence and what we know is still very heterogeneous. And also we see that a lot of meetings, there are symposia that are debating what spine instability and how we treat spine instability. So the first question is really, what do we need to solidify the definition of spine instability?
Well, I think this is a near and dear topic to certainly the three of us. I can remember ever since I was little, I guess, this just a very prevalent term that really just doesn't have a good definition, and critical decisions are made every day. And fundamentally, we just got to go back to the beginning and figure out how to define this. I just think it's certainly going to be radiographic. And hopefully, the newer technologies, I think we're on a cusp of really a whole new generation of technologies that will make us a lot smarter and a lot more accurate, and maybe be able to bring it to a lot more people. I think if you look at other more accepted types of stability, like for example the SIN score, which has been adopted pretty well in cancer, it really combines clinical information with radiographic information. So I think that's sort of where we're going.
Mm-hmm. John, what do you think?
Well, for me, it would be, first, it needs to be explainable. Mm-hmm. And second, it needs to be biomechanically rational. I'm trained in biomechanics, so it should make sense. Third, we need really good reference data to help us understand how to classify a patient as normal versus abnormal. And the most important thing, obviously, is a lot of clinical evidence showing it's effective.
So both of you mentioned that obviously we need imaging, we need also clinical data. But sometimes, especially with clinical data, if we are looking at patient-reported outcomes, we've seen in our field that there can be a bias when it comes to the outcomes. So to have a definition of spine instability and have it being used across different disciplines, different potentially treatment options, is it more important to have very well-defined, explained, rigorous radiographic parameters? Or should we more rely on the clinical side, for example, presence of pain with loading?
Yeah, so I honestly think you're going to have both, because we all have good examples of people that look like they move a lot for all intents and purposes, but don't really have any significant problems. We wouldn't even consider intervention, and some of these people that might be defined by current criteria as unstable. So there's going to be an element of the clinical portion of the problem that's just going to be important for defining like how you intervene and when you intervene. But I think you do bring up a really good point, and nowadays there's all this big shift to clinical outcomes, PROs and all, but what you measure really matters, because, if you're just looking at ODIs or whatever it is, that's sort of a general standard in a lot of outcome studies, that really may not necessarily apply to what you really want to know for that individual patient. So, I think, John will probably address this, but really looking at large, big data sets and being able to use more modern technology to get a lot of information quickly and make sense of it to what's meaningful for the patient. And it may just be, we may do an about face and come back to, more like patient satisfaction and just pain, yes or no, simple things rather than the more complex, but just trying to figure out what's meaningful for the patient.
I'm thinking, from the perspective of a patient, if unstable means that unless I get this treatment, I'm going to go downhill, that's good for the patient, I suppose. For me as a biomechanist, I'm thinking that there's intervertebral motion, there's something wrong with the restraints to intervertebral motion, so the vertebrae are moving abnormally. And but that doesn't matter if it doesn't hurt the patient, right? So it has to be a combination of the two, I would think.
I think there's going to be some other features. We may be combining, like what we traditionally looked at is just plain imaging and movement with maybe degenerative features, again, more advanced, say, for example, MRI, and I'm sure things even more sophisticated than that going forward. But just combining all these different parameters, it may be like more of a predictive analytics where you have 7 or 10 or whatever number of parameters that you kind of put into a big formula that a machine can spit out like that and just kind of give you a good idea of, what's considered more clinically unstable.
Right. And when I think about the question also, I wonder, you say pain on loading, right? Well, what does that mean? So there's all sorts of different pain, right? Yeah. And there's all sorts of different loading. So I would like to see a precise definition there. So if there were some standardization, so if a clinician says there's pain on loading, okay, I know that means that when the patient bends over, it hurts. And the hurt is not back pain, but it's, radicular pain. Yeah. So I like to see precise definitions come into play when we're talking about instability.
So does that mean, actually, that brings up another question. I do agree. We need both clinical and radiographic parameters and well-defined outcomes that we want to measure. But I believe that we still struggle with getting all the data. To have big data, we are struggling either of obtaining all the data, having those holes, or with radiographs, maybe not having a high resolution, high quality, or sufficient loading, as you just mentioned. So what do we do first? Do we first create definitions and then go back and redo some of the clinical studies to get to the point to start generating big data?
Well, from my point of view, I agree with John basically in principle. I think the main thing is it has to be reproducible, and you can't have all this heterogeneity because then you're just, nothing makes any sense. So yeah, I think we do have to get back to fundamentals probably. Every successful project starts with good, well-defined definitions and trying to rein something in that on the surface is heterogeneous and in making it into something that at least is measured homogeneously so that you can have some sort of dichotomous decision almost.
Yeah, and I think the nice thing is with artificial intelligence, we're getting to the point where a lot of the imaging stuff can be automated and generated very quickly and reproducibly. The issue is with the patient, right? So how do you standardize the response of a patient to the type of pain they're having? Because we've all heard clinicians say that it's more important to me that there is pain on loading than I see something on imaging, right? But again, what does pain on loading mean? And can you standardize that? So if one clinician says there's pain on loading, does it mean the same to another clinician? So I think those are very important questions. And so from an engineering perspective, I would agree with Charlie that we would want everything precisely defined and validated before we start to study.
And so both of you mentioned predictive analytics, artificial intelligence. Obviously, there has been a lot of development in spine field, and there has been a lot of development from the imaging perspective. in both X-ray and with X-ray and MRI sequences. So if we would, once when we have the foundation with well-defined instability and outcomes that we do want to measure, looking into the future, X-rays are 2D. So what about 3D? And will there be an opportunity to use artificial intelligence and then collect even more data for predictive analytics from a 3D reconstruction, radiographic reconstructions, to tell us better, not only the level of instability, but who would be a good candidate for a certain type of surgery?
Yeah, I think that's a good question for John.
Yeah, I think it's an excellent question. I think practically, we've discussed flexion extension studies with clinicians, and always, I'm thinking sagittal plane only. But I know the biomechanics data say that in a normal spine, even there's coupling. So when you bend forward and backward in the sagittal plane, there's also a little bit of axial rotation and a little bit of lateral bending. The problem is, I think in the degenerated spine, that can get out of hand. And I think that's what's causing the patient problems. So I think it's an excellent question. And at this point, I think, the AI that I know of is pretty much focused on the sagittal plane motion. But the truth is, AI is pretty amazing. So if we could generate enough training data to tell AI that, here's a case where the patient bent in the sagittal plane, but there was also a lot of, coronal plane and axial plane motion, coupled motion between the vertebrae. The AI can figure that out. I think as a grandparent, the better solution is to figure out how to stop degeneration. So the spine never gets to that point. It always stays with minimal coupled motion. But, we're far from that dream. So at this point, we have to start with the 2D sagittal plane motion and accept that they're in a degenerated spine. There's going to be cases with coupled motion. And we don't really know how to deal with it at this point, but it's very important, as any clinician seems to tell me.
Yeah, I just think, and this is like imagination, I guess, for the future, but I've seen what you have done even to this point, analyzing 2D data. I just really foresee that what you're going to do is develop standardized programs where people can just start collecting a lot of information. So you have a huge database, and then you'll just be writing and advancing programs to be able to mine that data. And we'll be able to pull out things that we maybe never have imagined or we're not focusing on, but, it'll just emerge, with these certain patterns in patients when you're combining all the clinical information with advanced imaging, with motion imaging. So it's almost like working backwards a little bit. But I think if you can identify just a bunch of different variables and let the machine then do all, it's something we never would have been able to do by hand. But it's, almost like going to the moon. You never would imagine doing that. And then it became fairly easy. Well, easy. And I just think, the next 5 or 10 years, there's just going to be a whole explosion of what now seems almost impossible.
Yeah, with the one caveat that we have to be collecting standardized data. So if we can talk the field into all getting together and collecting standardized data, we're going to move things much faster than if everybody has their own definition of instability. Everybody has their own definition of pain on loading. We need to standardize and then collect the big data and then let predictive analytics figure out how to sort it all out. So we can provide very personalized medicine.
And even if that's only within, it would be nice if everybody did that, but if we could just engage 20 centers or 100, it doesn't take the whole world to get on board. That's manageable.
Yeah.
And then I think we have something that's not garbage in, garbage out, right?
Yeah. No, I do agree. And the last quick question is, we are laying that foundation, what about the surgical portion?
Yeah.
There is a lot of development with different procedures, open MIS, different type of instrumentation, osteobiologics. Is it too early to think about that? What would be the right approach so that we have everything in sync? So when we have the foundation and well-defined parameters, that we can immediately proceed towards the treatment.
Well, I have a big opinion. I just think, what we've always done is treat. So we have all of these treatments for things when we don't even know what we're treating, right? We just, everybody's calling instability something. Nobody agrees on what it is. And we're throwing all these treatments at it. And sometimes it works and sometimes it doesn't because we have no idea what we're treating. I think we just have to back up, slow down, really understand. That's the whole problem. Just instability's just had this, it's just run away without ever really knowing what it was. You go back 60s and 70s, all this information, we haven't made any progress since then. So we just, we have to slow down, really get a definition, understand it, and then start our treatment applications. I just think, otherwise we're just going to be guilty of the same thing.
Yeah, I love that question because, I think that from the imaging perspective, we can get pretty precise and standardized. But I'm sitting here in these conferences hearing about, this guy's doing endoscopic, this guy's doing minimally invasive with a tube, this guy's doing, wide open, this guy's using this type of fusion, that type of fusion. And then we get to a study and we're saying, can we use stability to figure out who needs just decompression or who needs decompression plus fusion? But doesn't that depend on how you decompress and how you fuse? It seems to me that probably is important. And I don't know, how you're going to sort that out.
Well, and also just what stability is, like until you know what it is, like you use that word like we actually know what we're talking about, but we don't.
We don't.
Yeah. Well, I think we've outlined the first next steps that are really needed. And then when we have the foundation, then we can expand and get more people involved and design the appropriate studies, because that's always very often a limiting factor: sample size, number of patients, heterogeneity of the patient population and their pathology. Yeah. Thank you so much.
Thank you, Zori.
Thank you.